So my name is Michael Wang, and it's an honor to be invited today to speak at this meeting. So the topic of my presentation today is radiotherapy for brain metastases. I have no disclosure. So the outline of the talk today, I'll focus on two things. One is the management of multiple brain metastases and different modality of radiation treatment at our disposal. And the second one is to talk about management of resection cavities that's post-surgical resection for brain metastases. So a little bit background on brain metastases. Up to 30% of cancer patients eventually develop brain metastases. So there's quite a large proportion of cancer patient population. Some metastases are more likely to develop brain metastases, with the most common being lung, melanoma, and breast. Brain metastases can carry fairly devastating neurologic symptoms of sequelae. Therefore, it is a primary issue that we address on a daily basis at MD Anderson Cancer Center. Over time, the treatment recommendation or regimen for brain metastasis has shifted for the improvement of patient survival and outcomes. So over time, we have been doing less and less upfront surgical resection, as well as whole brain radiation at the same time, with the improvement of systemic therapy options and also imaging, MRI, better MRI quality. We have done more and more systemic therapy with intracranial activities, as well as more focused stereotactic radiosurgery for limited volume brain metastases. So the first part is we'll talk about management of multiple brain metastases. So the management of brain metastases, primarily the decision is based on the numbers as well as the volume of the brain metastases. The first type of radiation that we do on a regular basis is whole brain radiotherapy. So the positive of this treatment modality is that it's widely available. Any trained radiation oncologist can do this fairly quickly and safely. And we can start treatment as early as the day after a CT simulation. So also because we're addressing the entire brain all the way down to the foramen magnum, we can treat both gross disease as well as microscopic disease that we cannot see on imaging. And it is a fairly low cost treatment, and it can be made widely available to the general population. So the negative of this treatment modality is that, again, we're treating all of the brain tissue, so therefore it carries more neurocognitive impact compared to a more focal treatment approach. And it can interrupt systemic therapy by up to 4 to 6 weeks, because the treatment itself lasts 2 weeks, Monday through Friday, once per day. And usually would request 1 to 2 weeks of washout before and after for systemic therapy. Sometimes with our patients, especially in Texas, some of our patients they do live fairly far away from our hospital. Therefore, spending 2 to 3 weeks at a different city for radiation treatment sometimes can be logistically challenging. The next type of brain radiation treatment that we offer is stereotactic radiosurgery. So this describes both gamma knife as well as linear accelerator-based stereotactic radiosurgery. So the good thing about this treatment modality is that it spares the majority of the normal brain, because we focus on the disease defined based on a recent MRI scan. So at the same time, we're delivering higher dose, biological equivalent dose to the tumor itself, so that we carry a higher local control rate specific to the area that we treat. And in patients with a surgically challenging or surgically inaccessible lesions, we can treat these safely with the radiation, with the stereotactic radiosurgery. And because the treatment can range from 1 to 5 days, that results in less of a break in systemic therapy compared to whole brain radiation. The challenge with this technology is that it's not readily available. It requires a specially trained group of people who can carry out this type of treatment safely, including our neurosurgery colleagues. And because we're only treating areas that we define based on the MRI, we're not treating subclinical or microscopic disease elsewhere in the brain that we cannot see with the MRI. And we also will require higher level of surveillance imaging to monitor these patients to make sure that we're addressing any new or recurrent disease subsequently. So we can divide our recommendation based on the number of brain metastases established by several trials over time. So for patients with very few brain metastases at presentation, like 1 to 3 brain metastases, our decision is based on 2 important clinical trials. The first one's by Dr. Chenyang, was previously MD Anderson. This study looked at patients who received stereotactic radiosurgery for 1 to 3 brain metastases, whether they would benefit from additional whole brain radiation. And similarly, another trial was done by Dr. Brown. This is an alliance trial looking at the same group of patients with 1 to 3 brain metastases, also randomized to whether they would receive whole brain radiation or not. So these 2 trials kind of answer the question: is stereotactic radiosurgery alone to handle 1 to 3 brain metastases? So both studies have shown stereotactic radiosurgery improved neurocognitive function after radiation treatment. And although whole brain radiation sometimes improve the local control as well as distal brain control, however, they are associated with worse neurocognitive function. Therefore, we have historically been offering stereotactic radiosurgery for this population, as we have other salvage options should they develop new metastases elsewhere in the brain. How about patients with more than 3 brain metastases or 4 or more brain metastases? There's a Japanese study looking at stereotactic radiosurgery for patients belonging to this cohort. And it's a multi-institutional observational study. What they've found is that for patients who have 2 to 4 versus 5 to 10 brain metastases, treating these patients with stereotactic radiosurgery did not result in any detriment to overall survival. So this study gives us additional evidence to say stereotactic radiosurgery is safe and effective in patients up to 10 brain metastases. However, this is only observational study. Therefore, at the moment, we still don't have high-level evidence to support patients who have more than 4 brain metastases with stereotactic radiosurgery. So for patients with more than 10 brain metastases, up to 15 brain metastases, the median survival for patients who have only 2 to 4 versus 5 to 15 brain metastases is 9.5 months versus 7.5 months. So patients treated with the initial stereotactic radiosurgery for 5 to 10 brain metastases experienced a fairly similar survival, so 7.5 months versus 9.5 months, with no difference in the need for salvage whole brain radiation. So to further explore this patient population, Dr. Lee, who's one of our colleagues, our section chief at MD Anderson CNS Radiation Oncology, she has completed a phase 3 randomized trial looking exactly for this patient population of folks who have more than 4 and less or equal to 15 brain metastases. And these patients are randomized to 2 arms in a 1-to-1 with a 1-to-1 ratio. So the first arm receives stereotactic radiosurgery, primarily gamma knife radiation, following the dose prescription according to RTOG 9005 that defined radiation dose for individual brain metastases based on size. And then the second cohort are randomized to patients who receive whole brain radiation upfront. So this is the typical 30 grain 10 fraction over the course of 2 weeks. And most of these patients have received concurrent memantine, which was added to the trial after 2013. So the main primary endpoints for this trial is to look at memory function at 4 months and also local control at 4 months. So at both 4 months as well as 6 months, stereotactic radiosurgery again has shown better neurocognitive outcome compared to whole brain radiation. And overall survival is fairly similar. Additional results look at local control at 4 months. It's statistically insignificant. Distant brain control is also statistically insignificant. Stereotactic radiosurgery, because of shortened treatment time, does allow the patient to get on systemic therapy fairly quicker. So there's less of a break compared to whole brain radiation. And the toxicity difference is fairly minimal. So in summary, for patients with at least 4 brain metastases up to 15, Stereotactic radiosurgery associated with reduced risk for neurocognitive deterioration compared to whole brain radiation, as demonstrated by a series of different studies, both prospective as well as retrospective. There's no difference in overall survival comparing whole brain radiation with stereotactic radiosurgery. Therefore, we have been offering patients with up to 15 brain metastases with stereotactic radiosurgery up front. Yeah. So now let's look at a few different things we have done for patients who have to receive whole brain radiation and how to improve their neurocognitive outcome. So there's a study RTOG 0614 that look into the role of memantine for a patient receiving whole brain radiation for neurocognitive preservation. There's also a separate study looking at a specific type of a whole brain radiation called a hippocampal sparing whole brain radiation and its impact on neurocognitive outcome. So for RTOG 0614, the patients are randomized, the patients all receive whole brain radiation, 30 gray and 10 fraction, and they're randomized to placebo versus a memantine, which is a drug previously prescribed for Alzheimer's patient to see if there's a change in their neurocognitive decline. So the study has shown that there's a longer time to cognitive decline associated with patients who receive memantine compared to placebo. That's statistically significant with a p-value of 0.01. And the medication is fairly well tolerated overall and ended up and resulted in superior memory, better speed of processing, and also improved executive function after whole brain radiation. The only known side effect associated with memantine is severe nausea, and this frequently is detected fairly quickly, and these patients can stop treatment. Otherwise, patients seems to tolerate this treatment fairly well, and they can continue this indefinitely. So that's from a medication perspective. We can also try to improve neurocognitive outcome for patients receiving whole brain radiation by adapting a different treatment planning process. So this is called hippocampal sparing whole brain radiation, and the trial is a well-known trial, NRG CC001. So what is a hippocampal avoidance sparing whole brain radiation? So the rationale is that the hippocampal neural stem cells are responsible for the short-term memory of a patient. Therefore, if radiating this specific region in the brain, which was thought to explain for the decline in a patient's neurocognitive function after whole brain radiation. So how about if we can design a type of whole brain radiation that treats 98 or 99% of the brain volume, but specifically spare a small subregion where this hippocampal neural stem cells reside. This is a hippocampal sparing whole brain radiation. As you can see here in this image, which shows the radiation treatment plan overlaid directly onto a CT scan of the patient's brain. The area where the hippocampi is located are intentionally carved out of the radiation dose distribution. So this area has to satisfy specific radiation dose constraints for this particular study. So the outcome looked at here is the patient neurocognitive function after this type of whole brain radiation. So for CC001, patients with brain metastases are randomized to the conventional whole brain radiation plus memantine versus the hippocampal avoidance whole brain radiation plus memantine. One of the most important basic eligibility criteria is that these patients cannot have brain metastasis that's within 5 millimeters of the bilateral hippocampi. The reason being the 5 millimeter zone is thought to be the minimal distance we need to achieve the dose constraints required for this specific planning process. So this is a study showing neurocognitive failure. As you can see, the dashed line, the solid line represents whole brain radiation, conventional whole brain radiation. The dashed line represents the hippocampal avoidance whole brain radiation cohort. And at the 6 months, there's approximately 10% improvements in neurocognitive failure, which is classified as fatigue, difficulty speaking, and also short-term recall. Otherwise, there's no difference in overall survival, progression-free survival, and also other treatment-related toxicities. So this has established hippocampal avoidance whole brain as a viable treatment strategy for patients with brain metastases who cannot undergo stereotactic radial surgery, but they also don't have any brain metastases nearby the bilateral hippocampi. So next, we'll talk briefly about the management of resection cavity after brain metastases have been surgically removed. Now we'll look at specifically a trial that Dr. O'Brien has previously alluded to that compare pre-op versus post-op stereotactic radial surgery for brain metastases. So the role of surgery for brain metastases generally is reserved at our institution for large and symptomatic brain metastases. And we thought that the thought is that resection of a large brain metastasis will both improve the local control if stereotactic radial surgery is to follow initial resection. And second is that surgical resection is thought to quickly reduce or to improve symptoms when a patient is having significant issues associated with the swelling. So the management of the surgical cavity is based on the decision is the practice of our institution is based on two important trials. One was done at MD Anderson, and this is by Dr. Mahajan. So this clinical trial looked at patients with 1 to 3 brain metastases, and then looked at after initial surgical resection, whether stereotactic radial surgery versus observation resulted in benefit in local control. And from the study, we have seen that at 1 year, patient who received post-op stereotactic radial surgery to a cavity had significantly less local failure compared to a patient who was only observed. Therefore, this study has established post-op stereotactic radial surgery for resection cavity as the standard of care for patients with brain metastases. This NCCTG cavity trial looked at whether whole brain radiation is superior compared to stereotactic radial surgery after resection of brain metastases. And as similar to the previous studies comparing stereotactic radial surgery with whole brain for intact brain metastases, for the cavity, either the two modality did not result in difference in overall survival. However, whole brain radiation is associated with significant neurocognitive deterioration at 6 months. Therefore, further reinforced that stereotactic radial surgery is the first-line consideration for resected cavity after brain metastases have been removed. So in summary, the two cavity clinical trials concluded that there's a better local control with stereotactic radial surgery after resection of a brain metastasis that's not associated with any additional toxicities. And the second NCCTG trials comparing whole brain radiation with a stereotactic radial surgery showed that stereotactic radial surgery is associated with less impact on neurocognitive outcomes compared to whole brain radiation. Therefore, the two of them together establish stereotactic radial surgery as a standard of care for surgical cavity. So there are remaining a few issues associated with post-op cavity stereotactic radial surgery, which is currently established as the standard of care. One is the risk for leptomeningeal disease or leptomeningeal seeding after metastasis resection. And there's also additional challenges associated with post-op stereotactic radial surgery. One is the cavity sometimes would collapse, therefore it's difficulty defining where the cavity is. And sometimes this results in potentially larger volume of normal brain being treated unnecessarily. And also there's a question of the dose and fractionation. What is ultimate optimal radiation dose and fractionation for cavity? So looking at the issues of leptomeningeal seeding after surgical resection of brain metastases, there's a thought that at least 1 in 7 patients will undergo resection followed by standard of care post-op radiation will ultimately develop leptomeningeal seeding. Therefore, it is a legitimate concern for patients who have brain metastases. And this leptomeningeal, the risk of developing leptomeningeal disease based on several retrospective studies can be as high as 28%. In another retrospective study by Patel et al. Done in 2016, so this looking at patients who actually received pre-op stereotactic radial surgery, and very interestingly, they have shown that their leptomeningeal seeding risk is as low as 3%, there's raised a hypothesis that is the preoperative stereotactic radial surgery responsible for lower leptomeningeal disease, leptomeningeal seeding after resection. So this topic is currently being explored by Dr. Nana Yeboah, who is another faculty from our section at MD Anderson. And in this trial, she's looking at, this is a randomized trial comparing preoperative stereotactic radial surgery followed by the standard of care of postoperative stereotactic radial surgery. And the primary endpoint is leptomeningeal disease, the risk of leptomeningeal disease after surgery plus stereotactic radial surgery. And that study is still ongoing. So the remaining question is, what is the best radiation regimen for the cavity? We can all agree that for small cavity, less than 2 centimeters, we can achieve fairly good local control with single fraction stereotactic radial surgery, whether Gamma knife or linear accelerator-based SRS. However, for larger cavities, there's a question of whether these patients will benefit from better local control by using a more fractionated approach, sometimes done in 3 versus 5 treatments rather than 1. So these are retrospective studies. On the left, these are retrospective studies looking at patients with large post-surgical cavities getting single fraction stereotactic radial surgery. And on the right are patients who are getting multiple 3 to 5 fractions. As you can see, there seems to be an increase in the local control as a result of fractionated stereotactic radial surgery. This topic is currently being evaluated by Alliance trial 071801, and the trial is close to finish accruing. So we hopefully will see the results from this trial within the next couple of years. But this trial simply randomized patients with large cavities between single fraction stereotactic radial surgery based on specific volume, based on the surgical cavity volume versus a 3 to 5 fractionated stereotactic radial surgery treatment. So we're looking forward to see what this clinical trial will provide for this important question. And that's the end of my slide. Thank you everyone for your attention.